minutes. So we are going to start up here. So welcome. Shane, you want to start us out with this?
Sure. So, very large piece of tissue. Looks like some necrosis there.
Yeah, so that's a vessel.
Mm-hmm.
Not too happy vessel.
Not very much inflammation. There's kind of a bluish tint maybe around it.
So what would give you a dead vessel with not much inflammation but a blue haze around it? Like an ecthyma gangrenosum, exactly. Very good. And one of the more critical diagnoses we make in terms of risk to patients.
So I'm suspecting pseudoepitheliomatous hyperplasia.
So big pseudoepitheliomatous hyperplasia.
There's some neutrophils.
So
Inflammation.
neutrophils in the corneum, kind of a scale crust.
So the P and pus differential. The big green leafy nostrils.
So that would be certainly if we saw pustules down in the pseudoepitheliomatous hyperplasia. Here it's more on the surface. So what would be your differential for neutrophils in the corneum?
So the newts in the corn is plaids.
That's dermal papillae is the plaid. Anyone newts in the horn? P-tics. Yep. Psoriasis, tinea, impetigo, candida, sebderm, syphilis are the common things we think of. And what else do you see in the infiltrate?
So I think there's some plasma cells there.
Kind of wall-to-wall plasma cells. We got wall-to-wall plasma cells in the infiltrate, acanthosis, newts in the horn.
Syphilis. Could be differential.
And so syphilis would certainly be in the differential. This whole thing looks like it would be kind of warty, right? Any kind of warty thing that relates to syphilis?
Condyloma lata.
Condyloma lata. Very good. Okay, well, I'll walk you through this one. Epidermis is about normal. Dermis is somewhat attenuated because the glands sit very high, the secretory coil. The elastic tissue looks relatively normal. And collagen, which you see just as a negative background, is very much attenuated. So, elastic tissue stain rather than H&E, but I would say that if the history were right, that could be acrodermatitis chronica atropicans. Okay, let's move on to something different then. Okay, Rob, what do you see?
So a pretty intense interface infiltrate. Looks like more lymphocyte, probably, maybe some histiocytes.
So you certainly have an interface dermatitis, and your reedy pattern is effaced or accentuated.
Well, in some areas it looks accentuated.
And is that a usual thing for an interface dermatitis?
Not usually. Usually you think of it being a face.
So do you know any kind of interface that does just the opposite?
Like syphilis.
Like syphilis. So syphilis, anytime you see newts in the horn, plasma cells, interface dermatitis with accentuation of the reedy pattern, busy dermis, endothelial swelling, vessel with no lumen. All of those things would suggest the possibility of syphilis. Important to remember because it is epidemic proportions, easily cured if treated appropriately, and horrible consequences if not.
So there's a lot of serum crust in the horn, with lots of newts and bacteria up there. So there's obviously secondary impetiginized, whether this is primary impetigo or something else that's impetiginized.
Yeah, so either primary impetigo or secondary impetiginization.
It looks like it's creating a bulla as well, with very superficial, with some Klingons kind of cells looking.
So there are Klingons, just as in Star Trek, clinging on to the underside of the corneum, and acantholytic cells, and it's very superficial acantholysis. So what would be your differential for a superficial acantholysis?
So superficial acantholysis could be P. foliaceus,
So
staph
pemphigus
scalded
foliaceus, staph scalded skin,
bullous impetigo itself.
bullous impetigo. That's pretty good differential. There are eosinophils, which could lead you, to think of pemphigus foliaceus. I don't see them particularly in the epidermis. You certainly would want to correlate with clinical and also get immunofluorescence. The history on this one was just impetigo, bullous impetigo. And the bulla forms as a result of acantholysis, local toxin production. So if there's enough toxin to give you local bulla formation, why don't you get staph scalded skin all over?
Because it's not, staph scalded is from the systemic toxin, so you have.
So the toxin's well absorbed systemically. So who gets staph scalded skin?
You have good kidneys. So
exactly. So there's plenty of toxin being formed, but it's being cleared just as rapidly by your kidneys. So to get staph scalded skin, you have to be a kid, because the kidneys don't clear the toxin very well, or an adult in renal failure. But then all you need is one little spot of bullous impetigo. That's all you need to get staph scalded skin. In a kid, is there infection all over? Is it overwhelming infection, or is it a little bit in the umbilicus?
Usually a little bit in the umbilicus.
Yeah. So it's just a little impetigo in the umbilical stump, but there's plenty of toxin there, and the kidneys aren't functioning to clear it, so it produces staph scalded skin.
So this looks like maybe acral skin.
Yeah, it does look like acral skin, I agree.
It's maybe a pitted keratolysis.
So if that's a real break in the corneum, that absolutely could be pitted keratolysis. So you want to look to see if there are organisms there. I'm not really seeing organisms there, so it's possible that that's just cutting artifact.
Okay.
So let's look at what else is going on.
It looks like maybe some sort of a permatus reaction. Got kind of some granulomas, maybe forming around vessels and some.
So you certainly have vessels, and the vessel is healthy or thrombosed.
Thrombosed.
So thrombosed vessels, neutrophils, karyarexis, red cell extravasation suggests that the vessel is intact or the vessel is damaged. So damaged vessel, neutrophils, karyarexis, put it in the broad category of vasculitis, and any kind of vasculitis that's superficial, end deep, with necrosis of the endothelium, lots of thrombi, kind of dirty thrombi with neutrophilic debris. It's kind of characteristic for a septic vasculitis. So vasculitis, if it's post-capillary venule only, then you think of things like shoreline purpura, most connective tissue disease vasculitis, serum sickness, most drug-induced vasculitis. When you have deeper vessels, endothelial necrosis, then you think of ANCA-associated vasculitis, septic, and rheumatoid, and the thrombi in particular go with septic vasculitis. So this is a septic vasculitis, and it's a septic vasculitis on a palm, and there are collections of neutrophils, and I'll tell the clinicians in the room that it was enough that in some areas you had hemorrhagic macules on the palm, and in others you had hemorrhagic pustules on the palm. Any kind of sepsis, characteristically with hemorrhagic pustules on the gonococcemia. So things that are clues to gonococcemia: arthritis, septic joint, acral hemorrhagic pustule, usually a palmar or dorsum or side of the finger hemorrhagic pustule, would be classic for gonococcemia. So both the pathology and the site were things that were helpful.
So it looks like we had a very large palisaded granuloma around this vessel.
Is it a vessel or what is it?
Oh, well, it looks like a hair.
So there's a hair fiber.
Hair fiber.
So pus around a hair fiber would be
Like a suppurative folliculitis.
like a suppurative folliculitis. What kind of things give you a suppurative folliculitis?
I guess infectious things, so bacterial, fungal, and then also non-infectious like neutrophilic folliculitis decalvans.
Yeah, so there are some infectious things, non-infectious things like folliculitis decalvans, pustular drug. AJEP can be a superficial pustular folliculitis. This is pretty deep. And so you think of often infectious things. What are these little gray round things in clusters?
Those like staph grains?
Like staph. So this would be a deep suppurative folliculitis with staph would be...
Botry?
Yeah, or just a furuncle.
Furuncle, yeah.
And then tell me about the overlying tissue. So you got a furuncle, and then what's going on overlying?
Yeah, so you have some subcorneal split, kind of like and acantholysis. It's almost like a staph scalded skin kind of picture again.
So you have a furuncle, and you have at least locally produced exfoliative toxin. And then if the person is a kid or an adult with bad kidneys, then that'll go on to exfoliation all over.
Alright, so it looks like there's dermal infiltrate.
Dermal infiltrate. And where is the dermal infiltrate?
It's a little deeper.
A little deeper, and is it concentrated around anything?
From here, maybe vessels, but I
Maybe
can't really
vessels,
see vessel lumens.
but you're kind of questioning because you don't see vessel lumen. So it kind of looks like that ought to be perivascular, but there's no vessel lumen. Anything that you know of that characteristically gives you a perivascular infiltrate in the absence of a vessel lumen? And then let's look at the rest of what's going on. There is the infiltrate just perivascular, or is it interstitial too?
No, it's interstitial.
Kind of busy, right?
Mhm.
And then you look at the infiltrating cells. What kind of cells do you have?
There are lots of plasma cells.
Lots of plasma cells. Anything that you know of that gives you endothelial swelling, lots of plasma cells, and an interstitial busy pattern?
Syphilis.
Syphilis. Did the 3 cases of syphilis we saw look alike, or did they look very different? They looked very different. Osler called syphilis the great imitator because it does anything except vesicular or bullous lesions in an adult. You have to have a high index of suspicion, but there are some commonalities. They all the ones had an interstitial busy dermis, which is the most common feature histologically. Endothelial swelling, plasma cells present in about 2/3, a little bit of interface dermatitis. You start adding those features up, and they're usually, of 10 to a dozen possible features for syphilis. Your average case has about 4 or 5, and it can be any of those 4 or 5. So it's like ordering from a restaurant where you have column A, column B, and you get to pick 2 from column A, 3 from column B. That's what syphilis likes to do. It has a big menu of histologic features it can have, and it doesn't do the whole menu, but it picks a few from column A and a few from column B, and they mix and match, and you have to be aware of all of those combinations. The most common being the interstitial busy dermis, endothelial swelling, interface dermatitis, and endothelial swelling is a vessel with no lumen. Lymphocytes with too much cytoplasm. Usually lymphs sit on a background of white. Here the lymphs sit on a background of gray because there's cytoplasm. And I think on one of the earlier cases someone said, well, it's either a lymphoid or a histiocytic infiltrate. You can't decide because there's cytoplasm like histiocytes, but the nuclei look like lymphocytes. That's another thing that suggests syphilis. Skip that one.
So, lots and lots of infiltrate and lots of little vacuoles, pseudo-vacuoles mixed in.
Yeah, so lots and lots of vacuoles. Someone hands you a box, what's your first question?
Site.
Yeah, or what's in the box, right? Someone hands you a slide full of lots of vacuoles, what's your first question?
What's in the vacuole?
What's in the vacuoles, right? So they hand you a slide full of giant cells or little pockets of pus or circles, you want to know what's in them, right? So let's go higher. What's in the box? What's in the circles? So what's in the circles here?
With this chapter, I think about Lupus leprosy.
So Lupus leprosy would be something that would give you something in circles. What would it look like?
It should be, usually there are little clumps of, kind of more like a red hue.
Yeah, clumps of bacilli.
Right.
And here,
it's rimming the sides of it.
yeah, something that is dots, and they are distinctly at the periphery of the vacuoles. What gives you dots at the periphery of the vacuoles?
Is it histo that can do that?
So histo, they're evenly
the marquee?
spaced throughout. The one with the marquee sign where they're at the periphery, anyone?
So that's leishmaniasis.
Leash, correct. So leishmaniasis, they are distinctly like bulbs on an old-fashioned movie marquee around the edge, or makeup mirror, or anything you can think of with bulbs around the outside, right? So it's been called the makeup mirror sign or the marquee, movie marquee sign, with the the little light bulbs, the little circles at the outside of the vacuole. That's kind of typical for leishmaniasis. They will sometimes cluster within the vacuole into little groups, little clusters all at one side, whereas histo tends to be very evenly spaced throughout the vacuole.
Let's see. A lot of infiltrate.
Infiltrate, and is the infiltrate making any kind of pattern?
It's like kind of a granulomatous pattern.
Like a granulomatous pattern, and is the granuloma a ball? Is it a ring with something else in the center?
Ring with something else in the center.
A ring with something else in the center. And what would you call a ringed granulomatous infiltrate?
Palisade.
Palisaded, and it's palisaded with some multinucleate giant cells in the wall.
Right.
And so what's in the center of the palisade?
The fat.
There's fat, so it's sub-Q. Is that fat
What's
healthy?
No.
So,
It's like a lot of thickening.
yeah,
Around
so they're
it.
pycnotic nuclei, and it's very pale. Fibrin stains more intensely than anything else. This is staining less intensely than anything else, so it's just dead. Anything that you know that forms palisaded granulomas are on the dead center,
Like tuberculosis.
like tuberculosis. So that's kind of a typical caseous necrosis granuloma. If these things are about the size of a millet seed and were throughout your lung, what would you call it?
Miliary tuberculosis.
Yeah, like miliary tuberculosis, and this is just a miliary pattern in skin. And this was TB. What if you had all over your face little miliary caseating granulomas like that? Certainly disseminated miliary TB of the face could do that, right? Is there anything that's actually rosacea that they used to think was disseminated miliary TB of the face? How would you in Latin say disseminated miliary TB of the face? Anyone? Lupus miliaris disseminatus faciae, right? Because it looks just like disseminated miliary TB of the face, but it's actually rosacea, caseating rosacea. So that's how that condition gets its name and how it looks so similar.
So diffuse infiltrate. I don't see epi. It could be it's ulcerated.
Yeah, so it could be that it's ulcerated, and in fact it looks like we have like a fibrinous eschar with neutrophils on the top. So this probably is an ulcerative lesion.
I mean, really dense and diffuse. I see a ton of lymphocytes, histiocytes.
So
I'm not seeing much really neutrophils.
So lymphs and histiocytes, not a ton of neutrophils. I mean, a few. They're probably intravascular and they appear intact.
I can't really make out any vessel lumina. Or not many.
Yeah, so they're not a whole lot of vessel lumen.
I feel like in the setting of that ulcer, I'd want to make sure it wasn't somebody who was like immunosuppressed and had.
Absolutely. So, you'd worry about immunosuppression and then some kind of atypical infection. And in fact, this is an HIV patient by history.
But your differential is pretty broad in the setting of immunosuppression.
Yeah.
This could be somebody who's not mounting a response to leprosy. This could be somebody who has
Exactly. Could be all kinds of different things. Any cell types here?
A lot of plasma cells. I want to know site.
So plasma cells, and you'd want to know site to see if it's a Macarena site where the plasma cells are just being recruited. or not. And unfortunately, we don't know site on this slide. Here you have a cluster of nuclei, sort of on a background of pink cytoplasm.
It's probably a giant cell.
Yeah, and in fact, there are a lot of those. So it's kind of a diffuse interstitial and granulomatous infiltrate with plasma cells in an HIV patient.
Or
Could
definitely
be.
get an AFB. It could be like a gamma.
Yeah, so definitely get an AFB. Think of atypical organisms. Think of fungal. Think of acid fast. You got to think of syphilis, and this would be a gummatous lesion of syphilis, which is just granulomatous syphilis. And by history, that was exactly what it was gummatous syphilis. So you're absolutely right that you have to maintain a differential. This is an immunosuppressed patient with an ulcer, with granuloma, with plasma cells, and you have to think, what are all the atypical infections that will cause that? But as you're thinking acid fast and fungal, don't forget spirochete in that differential. Syphilis is at levels like it was back in the 1920s, and if you are not seeing syphilis, it may be seeing you in practice.
So there's the circle sign.
The circle sign, so let's look within that circle.
I think some lymphohistiocytic infiltrate, but it looks like plasma cells. Oh, and then there's organisms. So that looks like leash.
So some are at the periphery of vacuoles and some are clustered, so it looks like leishmaniasis. And leash is one of those conditions, like syphilis, that loves to recruit plasma cells. So there are certain conditions that love plasma cells. Leash is one of them, syphilis is one of them, Kaposi's is one of them. So that can be an additional clue for you. When you look histologically, there's a little bit of interface dermatitis. There's elongation of the redi. I might get a spirochete stain too, because you definitely see co-infections. If this is an HIV patient from an area where leash is endemic, there are definitely cases of co-infection of leash and syphilis that you see. So it'd probably be worth a spirochete stain as well. We don't know the history on that particular one.
So that kind of looks like a follicle.
Looks like a follicle, and what's in the follicle?
Pus.
Pus. So pus in a follicle.
I mean, that's suppurative folliculitis.
So suppurative folliculitis, which can be caused by?
Lots of things. Infectious, so fungus, bacteria. It can be a drug.
Yeah. So pustular drug, acne, bacteria, fungi. This person has just joined a spa and has itchy lesions in the axilla and bathing suit area.
That make me think more of like hot tub folliculitis.
Or like hot tub folliculitis, which is what bacterium?
Pseudomonas.
Pseudomonas, almost exclusively subtype O11, which just happens to be very resistant to chlorine. And swimming pool, hot tub, loofah sponge that sits wet at the edge of the tub, some kind of wet environment is typically what's at the cause for these.
Superficial trade, the collagen was a little wispy, but in the epidermis there's a little bit of, I don't know if it's just marking or actual bacteria.
Yeah, so you look at the top to see, the corneum looks like it's broken apart a little bit, right? So let's look, see, is there something going on? So is there something going on in that corneum?
Yeah, it looks sort of vertical.
So vertical things, and they're not hollow like vertical candida. So if they're vertically oriented bacteria, then what is it likely?
It's like
Erythrasma. And anything clinically that would likely be characteristic?
It's not like a inguinal site. You use a shine with Ehlers lamp, maybe a fluorescence.
Yeah, so it usually makes a lot of porphyrin so that it's brightly coral red fluorescent, and then histologically it's just bacillary forms, which will always be gray, very delicate and narrow, and vertically oriented for an erythrasma. Very good.
There's some giant cells and neutrophils.
Giant cells
There's some holes too, I think.
and definitely, more giant cells and granuloma, and that granuloma is surrounded by lymphocytes. So this is like the anti-sarcoid, right? Sarcoid would be granulomas in the absence of lymphocytes. Naked granulomas, these are like winter coat granulomas. They're not just dressed, they have extra layers of lymphocytes, right? So this is a heavily, heavily dressed granuloma with lots of lymphs. So do you know any kind of heavily dressed granuloma, lots of lymphocytes, with multinucleate giant cells and sort of irregular atrophy and pseudoepitheliomatous hyperplasia of the epidermis? What kind of category would you start thinking of?
Infections?
Yeah, infectious, and more an acute infection or more a chronic infection?
Chronic.
So, and your chronic infections, what kind of things do you think of?
Spirochete?
So spirochete, absolutely. You would have to consider syphilis in this. So gummatous syphilis, absolutely. So you get a spirochete stain. That can be dicey. It may be negative in gummatous syphilis because the number of organisms is very few. So you need a high index of suspicion for gummatous syphilis. What other kind of chronic infections?
TB?
Yeah, or acid fast in general. So fungal, acid fast, those tend to be chronic smoldering infections often, and spirochete. That would be the groups to think of, and this clinically was lupus vulgaris. So chronic cutaneous TB usually affects the face, like the face was mauled by a wolf, which is where it got its name lupus. Vulgaris meaning common, just like verruca vulgaris, common wort. So common lupus, back in the days when TB was common, was cutaneous TB of the face. And then there was that other red one, which was lupus erythematosus, right? But common lupus was lupus vulgaris, was TB, which is why if you thought someone had disseminated miliary TB of the face, you would call it lupus miliaris disseminatus facii. Because that histologically looks like disseminated miliary TB. We're doing in terms of time. We're doing okay.
So, see a lot of almost like cracking, makes you think of like rhinoscleroma.
So rhinoscleroma would be usually sheets of circular vacuoles filled with bacilli, so they look like globi, but lots of plasma cells in the background.
Right. And then...
so is this filled with lots of things that look like globi, or do these look different?
They look a little bit different.
What do these look like?
So they look like they're lining up at the periphery, so I guess you could think about leash.
Yeah, so this looks more like leishmaniasis. And then in the differential for leishmaniasis, if it were more evenly spread, histoplasmosis, Penicillium marneffii. And then the other one that can do that is trypanosomiasis, which we don't have a whole lot of in the U.S., but trypanosomiasis is related to leash, and the organisms look similar in tissue. If it's a cutaneous ulcer, it's more likely leash.
What about granuloma inguinale?
So granuloma inguinale tends to be pseudoepitheliomatous hyperplasia with pus, lots of plasma cells, likely to be beefy, red, friable genital
They can be
lesions.
intercellular too, but you not.
They are
vascular.
they are intracellular, but not so much in a vacuole. And they're usually harder to find. You can do plastic embedded sections, cut 1 micron thick, kind of helps to see the organisms in granuloma inguinale. And then the clinical helps a lot, that it looks like a chronic beefy red granulation tissue venereal disease.
So this is a dense and diffuse infiltrate in the dermis.
So dense and diffuse
almost
infiltrate.
like a palisading granuloma in the center there.
So palisading granuloma with what in the center?
Caseous necrosis.
Is it caseous necrosis or is it little fragmented black nuclei?
Well, it's always the second, so little fragmented black nuclei.
So if you have pus within a palisaded granuloma, what's your differential?
It's an infectious category, so like even bacterial, like warm body, I think leprosy,
And often their abscesses get to be kind of stellate within that palisading granuloma.
So like the Clat's differential.
So Clat's, which includes
Cat scratch, atypical mycobacteria, I think lepers, no.
so LGV.
LGV, sorry.
So cat scratch,
LGV,
lymphogranuloma venereum, atypical mycobacteria,
tuberculosis,
or tularemia and sporotrichosis. And this was something with a lymphangitic spread up the arm.
So it would be more of your sporotrichoid differential.
Sporotrichoid, which would include
sporotrichosis and like mycobacteria,
marinum, the atypical mycobacteria. So several of those from the list.
Yeah.
And then don't forget nocardia on that, especially in the south.
Okay.
Because nocardiosis can go either way. It can be ulceroglandular or it can be lymphangitic.
Okay.
So when you look at that Clat's differential, some of them are ulceroglandular, some are lymphangitic. Ulceroglandular means you get an ulcer and a suppurative lymph node. Others are lymphangitic, which means you get nodules not at the lymph node but along the lymph vessel. So in that Clat's differential, cat scratch, ulceroglandular. Atypical mycobacteria, lymphangitic more likely. LGV, ulceroglandular. Atypical mycobacteria, more likely lymphangitic. Tularemia, ulceroglandular. Sporotrichosis, more likely lymphangitic. So between clinical and pathologic, you can divide up your possibility and kind of cut it in half, 2 groups.
Looks like we have some acantholysis with maybe a subcorneal bulla.
Subcorneal bulla, and is there anything in the bulla?
Yes, they're neutrophils.
So subcorneal bulla or subcorneal pustule with acantholysis differential.
So well as impetigo.
Impetigo.
So I guess the suppurative folliculitis. No, never mind.
Well, if there were a deep suppurative folliculitis, you could get the toxin-producing or toxin-mediated acantholysis near it.
So I guess this could also be some sort of drug reaction.
So drug, pustular drug could do it. Bless you. Other things, what if it were antibody-mediated acantholysis and then secondary impetigo?
So, like, Pemphigus vulgaris.
So vulgaris tends to split suprabasilar. Which one tends to split up here?
BP?
No, foliaceous.
Oh, okay.
Pemphigus foliaceous. And then the other one is IgA pemphigus, is a subcorneal pustule, sometimes with acantholysis. So IgA pemphigus, Pemphigus foliaceous, staph, scalded skin, bullous impetigo. That's kind of your differential for this level split. Fulgus ovagum is an endemic form of foliaceous. So, yep. Would be exactly. And Fulgus ovagum, if you speak Portuguese, means wildfire. So the people in the foresty areas would get wildfire, which was an endemic Pemphigus foliaceous. And if you lived in the city, you didn't get it, which suggests that it's an arthropod vector of some sort causing it. And interestingly, city people don't get it, but if city people go to build Brasilia and carve it out of the jungle, they get it. And then in Brasilia, if you live in an apartment building, you don't get it, but if you sleep in the park at night, you get it. So, all of those things suggesting there may be some arthropod vector for this immunobolus disease, whether it's cross-reaction to a saliva or what. It could be.
It's like a superficial perivascular and interstitial infiltrate. Mucin or just some like solar elastosis in the dermis as well.
Yeah, probably solar elastosis because you can really see that they're elastic fibers.
Yeah. See, the reedy pattern is kind of effaced a little bit.
So an effaced reedy pattern.
And then it's not quite interface dermatitis, but I think syphilis is still there's definitely a little interface there. Yeah.
And you just said it's not quite interface because it's kind of spongiotic, but it's interface, but no, it's spongiotic, but no, it's interface. I can't decide, is it spongiotic or is it interface? What things are you supposed to think of when you can't decide if it's spongiotic or interface?
Drug viral and syphilis.
Drug viral and syphilis. Drug viral and syphilis. Drug viral and syphilis. In case we didn't mention it, you should think of drug viral and syphilis if you can't decide if it's spongiotic or interface. So does this one have long, slender reedy?
No.
Does it particularly have endothelial swelling, or do you see lumen?
I see lumen.
A little bit of a busy dermis. That's about it. And then you've got interface. And so a lot of the things that we depend on, plasma cells, newts in the horn, not there. Does that mean this patient should get TABs because it's their own fault? They should have had more histologic features if they wanted their syphilis treated. Hopefully not. So again, one of the other rules that you hang on to is if you can't decide if it's interface or spongiotic, there's certain things you're supposed to think of. Drug viral syphilis, drug viral syphilis, drug viral syphilis. And in this case, it wasn't drug and it wasn't viral. So it helps you narrow it down.
Another pretty dense infiltrate. Maybe a few vacuoles.
So maybe a few vacuoles, which means you'd always want to look in the vacuoles, right?
Yes.
In this case, I don't see much
There's
in the
not really
vacuoles.
anything
Yeah.
There.
But there's certainly, what are all of these cells?
Those
Look like ants with segmented bodies.
neutrophils.
Neutrophils. And all those neutrophils are sitting next to,
Probably a follicle.
yeah, those are sebaceous glands, so a follicle, and there's a little hair follicle with the hair. So,
Maybe suppurative folliculitis.
suppurative folliculitis, what things cause suppurative folliculitis?
Bacterial infection.
Yeah, bacterial infection, fungal infection, acne, pustular drug. So some of these, they're common differentials, and it comes down to, there are like 3-4 things in the differential you're supposed to think of, and so it's just learning those common differentials because they're part of practice.
All right. So it looks like busy, deep dermis, just mildly acanthotic epidermis.
So is it mildly acanthotic, or is it a little more than that?
I guess it's a little more than that.
Maybe to the point of
PEH.
pseudoepitheliomatous hyperplasia, and then what's this cluster of things that look like ants?
So pus neutrophils.
Do you have a differential for PEH with pus?
Right, so this would be our halogenoderma, chromo, blasto, granuloma inguinale, leash, and then Pemphigus vegetans.
So here come big green leafy veggies, and so you're going to want to work your way through each of those possibilities. And if we look in the dermis, I'm seeing some circles. I'm not seeing a lot of organisms in there.
Mm-hmm.
But you're definitely going to want to work through that differential, and this GRU leash, one of the clues might be the plasma cells, which leash, just as much as syphilis, loves to have plasma cells. Granulomatous leash, like most things, when the more granulomatous they are, the less you're going to be able to find organisms. Right? And there are a lot of leash cases where you grow it, but you don't see it necessarily on path. If you searched, you might find one or two in there. But a granulomatous leash, you're less likely to find the organisms. So you're in clinic and you're back in Ohio, life is good, and you've got a college student who was just down in South America doing a Habitat for Humanity thing, building houses, and came back and they've got this ulcer that just won't heal on their hand, and you're thinking, I know this has to be leash, right? But you need to prove the diagnosis, and your biopsy is showing PEH with pus. You say, okay, I got to culture this. So what do you do? Who do you call?
Oh man, is this one that's like the Navoy that grows on that
So
NNN medium?
There's triple N medium, leishmanial media, and where do you get it?
Guessing the big boys.
So CDC will send it to you. Your state health department will send it to you. Whatever university is near you may have it. Probably any military base near you has it. What happens is the state health department calls the military base, and the military base gives it to the state health department, and they send it to you. And then it may go back to the Department of Defense to grow. And then what do you have to do? Do you need dry ice, or do you need an incubator, and it goes in an ambulance and an incubator? How do you do it?
Listen to the big boys.
Yeah, exactly. They'll tell you it. But it's as easy as pie, because it's a liquid, you drop the punch in, and it goes at room temperature. You just put it in the post and send it back, and by the time it gets to them, the swimmers are swimming. Because it's not so much a culture as it is getting all of these amastigotes to convert into the flagellated organism that goes swimming through the medium, and then they just spin it down and look at the medium, and you've got all those flagellated organisms there by the time it gets to them through the mail. So it's actually really easy. You call, they send you the medium, you do your biopsy, you just drop it in, you send it at room temperature. The only thing you have to worry about is if it's the middle of winter, you don't want it to freeze.
So half the year.
Yeah, other than that, you're fine. Okay. Okay, we got about 10 more minutes. Let's grab some. Okay, so that is some kind of stain with a blue background, which could be a stain for acid-fast bacteria. Mm-hmm. And if we had things that are granulomas, and those granulomas are going parallel to the surface, what kind of things are you thinking of?
Tuberculous leprosy.
Tuberculous leprosy. And then what if you've got lots of circles that look like there might be globi? So something that's kind of halfway between tuberculous and lepromatous. Like borderline. So indeterminate leprosy is an early lesion that hasn't decided, is it going to go tuberculous or is it going to go lepromatous? It's that early stage of leprosy, could go either way. Borderline leprosy is that whole group of patients who are in between. Their immune system is somewhere in between. It's not the heavy immune granulomatous response of tuberculoid. It's not the totally ineffective response of lepromatous. It's somewhere in the middle. And then if there are lots of dense lymphs like that, this could actually be someone who's being treated and has lepra-type reaction, where they are having a downgrading or reversal type reaction, which is lymphoid mediated. Which reaction is neutrophilic? Erythema nodosum leprosum, which is leukocytoclastic vasculitis to locally formed immune complexes. And which one is stellate infarct in a patient with indurated skin and you see thrombosed vessels filled with organisms? That's Lucio's phenomenon. And Lucio's phenomenon is almost exclusively in northwest Mexico. So everything that sits south of San Diego is pretty much where you see Lucio phenomenon. So most of the papers on it come out of Guadalajara because they've got a big hospital there, med school, and it's the area of the world where you see it. Okay.
Super atrophic epidermis, and you've got these huge well-formed granulomas that look like globi.
So,
not really so much. It's more just a histiocytic infiltrate.
So it's more just a histiocytic infiltrate, not a lot of giant cells, and you've got huge globi. So what are you thinking?
Lepromatous leprosy.
Lepromatous leprosy, absolutely. And this patient had kind of stretched, taut skin, like a big face, and they were actually sent to see you because they have these stellate infarctions on their extremities, like retiform purpura, and you biopsy and they're full of thrombi. That's Lucio's. And you will see it. There's a good chance you may see that sometime in your life in practice, and it's just going to come out of nowhere. You're going to see these patients.
So here there's kind of perivascular lymphocytic infiltrate, and don't really see that well lumen. There's maybe a hint of interface and maybe some slight sunder, really rigid. So I'd be favoring syphilis, but I'd want to look over.
But I see a little sponge here.
Yeah.
Are you sure that's interface and not sponge? Could it be both?
I think it's both.
Is there anything you should think of when it's both?
Syphilis.
And
Drug and viral.
And drug and viral. And then, you already thought of syphilis, and you got a little bit of a busy dermis, and you got perivascular infiltrate, but I don't see any lumen. and there's a little too much cytoplasm to those lymphs, and so you're going to get a spirochete stain.
Definitely looks like you have acanthosis, maybe even pseudoepitheliomatous hyperplasia. And there's definitely a large infiltrate taking up most of the dermis.
Okay. So we sort of have pH and pus, and then a large infiltrate taking up most of the dermis.
They look histiocytic.
So they look histiocytic. Anything sitting within the histiocyte?
Maybe.
Some little gray things, maybe. So what are you thinking? Possibly.
It could be leash.
So it could be leash.
They're not the best looking globi I've ever seen.
Yeah, so
but I'd want to rule that out.
Absolutely, you'd want to rule out leprosy. So you'd get an acid-fast stain. You'd hunt any stain that might help you for leash.
Giemsa.
Giemsa just helps you see the kinetoplast a little more. Other than that, you see them pretty well in H&E. What if you end up, you've hunted, you've searched, you've stained, can't get anything. You've done routine cultures, you're not getting anything on bacteria or AFB or fungal.
I'd still worry about leprosy, but I think syphilis is also in that initial differential.
Syphilis is absolutely in that initial differential. So, you'd worry about, could this be a granulomatous syphilis? And what if you were, the patient had a travel history and you wanted to culture for leash?
I'd call the CDC.
Yeah, pretty easy. Call State Health Department or CDC, and they'll send you the medium, you do your punch, you pop it in, ship it at room temperature. So it's full of circles, and there's gray stuff in the circles, kind of clumpy, long, skinny things that clump.
Right. So that's like the one.
Looks kind of like lepromatous leprosy with globi, but what's with all the neutrophils here? Anything that's going to give you a neutrophilic reaction and vasculitis in someone who has globi?
Like if they're a pregnant patient.
Like they're a pregnant patient, and what do they develop when they're leprosy and get pregnant?
Then you painful areas on the back of their calf.
Which we call
the
erythema nodosum leprosum. Very good. Okay, it's clinic time.
How do you treat that in a pregnant woman then? You can't do thalidomide.
Yeah, exactly. So you obviously cannot do thalidomide in the pregnant woman. You can do prednisone, you can do clofazimine, and you call Carville, call your state health department. They will walk you through.
Okay.
Yeah. What you need to do is make the diagnosis. They will help you with treatment.